Specialty Stories, session number 133. Whether you are a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, and I hope you are having an amazing day. I want to thank you for being here, and I want to ask you a favor. Can you share this podcast with a friend, a colleague, classmate, with someone who you think would be interested not only in learning about our specialty today, but about all of the specialties that we have had on this podcast. Today, I'm joined by Dr. Alex Dressler, an anesthesiologist who specializes in pain medicine out in the community. He's been out of training now for 1 year, and he's got some good insight, especially as a new person, a new physician out in practice, and what it's like to build up that practice. We start the conversation by talking about what drew Dr. Dressler to pain medicine and anesthesiology to begin with.
So initially, as I did undergrad in Connecticut, and I was doing research at Connecticut Children's, I was pretty sure I was going to do surgery or pediatric surgery. Had that going most of the way through medical school. Even did a short summer thing between first year and second year. Convinced I was doing neurosurgery. Then got to my surgical rotation, and I had the chance to do an anesthesia elective, knowing very, very little about it. But thinking if I was going to be a surgeon, I might as well know something about the anesthesia side, and that kind of just won me over. I think it's an interesting field. There's so many little subspecialties within it that I would say most people, even people in medicine, probably don't realize there's so many small, intricate niches that you can kind of be a part of. And that was something that really appealed to me.
Very cool.
And then from the for the pain side, I still had that side of me that enjoyed, some of the operating room procedures and procedures with patients. So when I got to that actually during my second year, my PGY2 year in anesthesia, and just basically a weekend, I knew that was ultimately going to be a big part of my practice moving forward.
So I think a lot of students listening to this, when they hear pain management, they think, "Oh, this is the issue with our opioid epidemic. It's just doctors handing out prescriptions for Oxy and Percocet and stuff." What does a pain management physician do?
I think that's a great question, and my day varies. I'll have patients where things are more heavily shifted towards procedures. Other days more shifted towards certain medications. Very rarely are kind of the opioids or opiate medications the first thing that we jump to. There's so many adjuvants, other medications that are useful. A lot of the typical pain we see is back pain, neck pain, with pain going to the arms, going to the legs. That's kind of the bread and butter for most pain groups. And a lot of times that's from nerve irritation close to the spinal cord or further out. So the pain physician is taking the time through physical exam, through various tests, such as EMGs or nerve conduction studies, looking at the MRI, to kind of find the source of that pain. And there's things like injections can be very useful, steroid injections, to kind of calm down some of the irritation, the inflammation with the nerves. And I think that's often, people think of it as, that people just want to do injections, but these really work. In my day-to-day practice, I have people 3 to 5 days after these injections who do fantastic. And I think it's just kind of balancing some of those procedures with some of the other extra medications to kind of improve people's functional status. Those opiates and opioids are useful after traumatic accidents, after surgeries, and extremely useful, obviously, in cancer pain, end-of-life cancer pain, but often aren't the answer to the most of the pain patients that we see.
When you were looking at pain management, obviously you're in your anesthesia residency. Were there any other subspecialties that were drawing your interest?
The pediatric anesthesia is something that I was interested in, and actually, for a brief period, thought about doing a second fellowship. Um, I think you really are in all of the anesthesia subspecialties. You're taking the time, and often seeing people at they're the worst. They're about to have surgery. They just had a really bad accident. I think being able to relate to being able to get kind of on the kids level at times, and it's a scary thing to have anesthesia as an adult. It's even scarier to have it as a child, and then being able to deal with both the child, the pediatric patient, and with the parents during these difficult times. I think takes a special skill set, and I admire the pediatric anesthesiologists who do it every day.
Yeah.
It's something that I thought I could see myself doing, but ultimately, I think I just had to focus in one direction.
That's good. There's a lot of people these days doing multiple fellowships. I'm like, wow, that's a lot of training.
Yeah, it was time for me to get a job, I think.
Yeah, time to pay back those loans.
Yeah.
What does a typical day look like for you?
On the pain days, I typically see patients between 7:30 and about 3:30 or 4. And in the offices I'm working in now, it's a mix of both office visits and procedure visits. I'll have patients referred by their primary care doctors or by some of the surgeons for various pain conditions. And on the same day, I'll also have patients returning for procedures, and they may have had to delay their procedure for a number of reasons, for insurance reasons, getting things approved, or if they're on some of the different blood thinners and had to hold them. And you can see anywhere between 20 and 25 patients a day typically. And some days there are mostly procedures, and because there's less documentation required with some of those, and you already know the background history. There's less review of imaging and review of their history. On those days, you may see a few more patients if there's more procedure slots.
What are some of the biggest misconceptions around pain management and pain medicine?
I think two of the things we've kind of already hit on, that that the pain management, pain medicine docs are going to take over every prescription. We have a lot of people show up and just expect that they've been on a certain prescription, they've had certain medications for 20 years, that they see us. And a lot of some of the community doctors have decided that they may not want the opioids as part of their practice. For various reasons, they're just not comfortable managing them at certain levels. They're concerned about legal repercussions about some of their prescriptions, so they refer them to us. And sometimes there's, I think, just the misconception that we're automatically going to take over some of these prescriptions. And a lot of times, the first visit with some of these patients is kind of readdressing goals and establishing what may be the new norm. And I think on the flip side of that, there's also the misconceptions, especially in within medicine, often from other doctors, that the pain medicine doctors just will inject anything and everyone for financial reasons, which I think is a very unfortunate misconception, and it's obviously never our goal.
What percentage of patients that you're seeing in your pain management clinic do you actually end up doing a procedure on, do you think?
I mean, I think maybe 60 to 75%, and that may actually be skewed towards the higher side. A piece of that is a number of patients that I see have been seen by our team of nurse practitioners prior to seeing me. So sometimes I'll be seeing patients for procedures, but they've already had a full workup and had some of the medications trialed with our team of nurse practitioners who do an amazing job.
Yeah. What does the training path look like to get to become a pain management specialist?
So I think pain is one of the interesting things. It truly is a multidisciplinary team. For the pain fellowships, traditionally it is someone coming from anesthesiology, someone from physical medicine rehab, the PM&R pathway. But is also, I think that's probably the majority, but there is also neurology can go into pain. They're often a huge resource for us for some of the head and neck pain and headache pain. And psychiatrists also can come into can go into the pain pathway.
I've
During the
seen
interview
some
process for fellowship.
radiologists too. Have you seen radiology?
Yeah, so when I interviewed at one of the places for fellowship, I was interviewing with a radiology resident, and his brother actually was one of the first people to go kind of that radiology to pain pathway.
Nice.
There's a number of musculoskeletal radiologists that do some of the similar procedures that the pain doctors do, because there is kind of a fair amount of crossover there. So often some of the radiologists who are looking to kind of either hone their skills or improve their skills on some of the medications or diagnostics, we'll do an extra pain fellowship, and they have a different, slightly different skill set, but obviously add a lot to the multidisciplinary team.
Cool. How competitive is pain?
Pain is probably one of the more competitive fellowships for a number of reasons. There's the perceived lifestyle. Obviously, when you're going through anesthesia residency, you're on call a lot. You spend a lot of time in the hospital. So the thought of having, a more typical schedule, I think, draws people. Another thing that draws people in is that there's the potential for a lot of research within pain, because a lot of what we do is, or a lot of some of these conditions is still very poorly understood. And even separate from that, there's a lot of the technology side of pain often draws in a lot of people, and is the neuromodulation technology side is one of the things that really drew me to pain the more and more I learned about it.
Yeah. All the kids coming up with their tech devices want to play with tech their career.
Yeah.
Makes sense.
Yeah.
What does call look like for you?
So right now I work some of the weekend calls. I typically work Saturday overnight. One of the hospitals that I'm part of a private group that covers a number of surgical centers, of outpatient ambulatory surgery centers, as well as one of the hospitals here in southern New Hampshire. And so I do take in-house trauma call for anesthesia, typically on Saturday nights, a few times a month. And it's a mix of urgent or emergent cases that have to go during the night, as well as some of the obstetric anesthesia coverage.
Do you feel like you have enough time for life outside of the hospital?
I definitely think I do, and I think that is one of the reasons I chose pain, was allowing balance with family. I have two young twin girls, and my wife is also a physician here in the New England area. So it's difficult at times for us to balance it. But I think pain and anesthesia were two of the pathways that allowed me to still prioritize family.
Yeah, cool. Once someone is done with their pain fellowship, are there further opportunities to subspecialize?
There are typically not in traditional training, but there are PEDS pain fellowships. There's a handful of PEDS pain fellowships, I believe, throughout the country, and it's often people doing both pain and pediatric fellowships. But I think within the different communities, and especially within the different practices, people will gravitate towards different things. I think everyone does a fair amount of what people kind of consider the bread and butter pain, the neck pain, the back pain. But there are people who do subspecialize in, seek further training in headache medicine, in things like pelvic pain, female pain, as well as people who focus a lot on the oncology related pain. And it's every group is a little different. And obviously the major academic centers, often you have people who see certain things because their research interest lines up with that, or just because their personal clinical interest lines up with that. In the private practice I'm in now, we all kind of enjoy a little bit of everything. So people still see most of everything. We're not really focusing too much on just one aspect.
Yeah. For the osteopathic medical student listening to this, or resident even listening to this, what obstacles or what do they have to do to overcome any sort of negative bias towards the DO world?
I think there's probably some programs throughout the country that are still very that still have some bias towards MD only versus the DO pathway.
Mm-hmm.
Training at University of Pittsburgh for both residency and fellowship the program for both anesthesia and pain had a fair number of DOs. So it wasn't in my day-to-day training wasn't a big split for me. Everyone was kind of on the same level playing field. I think it's obviously looking. I actually had gotten that question from a medical student who was doing an away rotation and was applying for anesthesia, had an interest in pain.
Mhm.
And my biggest piece of advice was just, you can look at the program leadership, look at the attendings within the programs, and just find some that obviously have valued the different skill sets, or have allowed, or have had some of the DO physicians become leaders within the program. So I think that, and you can look at most of the residencies now. You can look at all the residents. If you look at 4 years of anesthesia residence and there's not a single DO student, it's obviously that program may not be the place.
Yeah.
So I think it's doing some of your research and just finding the places who are open to just finding the best candidate, not necessarily looking for certain designations.
Yeah. What do you wish primary care physicians knew about what you're doing day in and day out as a pain management specialist to better help you and better help their patients?
I think just there's so much more to treating pain than prescriptions, and having us take over prescriptions. I think it's just they also may not understand all of the intervention options that we have. I know sometimes that there's that perception that we jump to injections, but some of these injections really work, and we're able to target pain. Things, more advanced modalities, things like spinal cord stimulation, peripheral nerve stimulation. Now we're able to put in peripheral nerve stimulators with just ultrasound through needle-sized holes, as well as things like dorsal root ganglion stimulation. All of these things are great options for people who have dealt with pain for years and years and just haven't been able to get a hold of it. So I think they just really understanding some of the different intervention options that have even progressed over the last 3 to 5 years that may not have been around when they did initial training.
What other specialists do you work the closest with?
We work a lot with the orthopedic surgeons, the ortho spine doctors, as well as the general orthopedic surgeons for some of the joint pain. We work a lot with neurosurgery, neurology, the rheumatologists, primary care doctors, as well as some of the more focused pain things. We work with the general surgeons post hernia pain, often post surgical pain people have. We can often have nerve-based, like neuropathic pain after simple surgeries that went very well and may have fixed the problem, but they can have incision pain. Work with breast surgeons, plastic surgeons. Patients often have pain after both cosmetic procedures as well as post mastectomy for cancer-related pain, and definitely the oncologist, malignant related pain. End of life cancer pain is something that's very difficult to treat, and I often think it's very valuable of getting in some of the pain physicians involved and getting some of the patients, those patients really worked up through some different pathways and trying to find all the options for them to make them comfortable in the end.
Yeah. With that mention, do you work a lot with palliative medicine specialists as well?
We do, and I have a recent patient actually, that this is, I think having the 3 teams all involved and everyone being able to look at things differently, I think it is essential. Palliative obviously is looking for optimizing, creating the best quality of life towards the end, and sometimes people think palliative medicine can only be helpful in those last days. I think that's another misconception.
Yeah.
Actually, in pain fellowship, we spend time with the palliative physicians, understanding better what they can offer,
Okay.
because they may be someone that we have to lean on as well towards the end. And it can be months, it could be years that they can be involved. And there's a lot of good studies that show that when palliative medicine is involved, quality of life is significantly improved, and also duration of life is improved.
Yep.
So I think those are things that something that even we as pain medicine docs may not think about. Getting palliative involved is really key in some of those patients.
Yeah. So you're relatively new out of training. What would you go back and tell yourself before training now that you've been out for a little bit?
I think it's probably just, look at the big picture. Don't stress out about each and every test. Anesthesia is one of the specialties where there's a lot of tests you take in. Training exams every year. Our written boards had changed to taking the first part of your actual written board at the end of PGY 2 year, an advanced exam at the end of your 4th year, and then the oral board actually had shifted to an applied exam now. So it's a mix of half day oral board, half day or half the exam you take a more applied exam. So actually doing ultrasounds, looking at echoes.
Mm.
So sometimes you get wrapped up in preparing for the next test, but really I think taking a step back and ensuring that you're getting the most out of each and every patient encounter, learning from each and every patient that you deal with, because there's so many times when I see someone now, either on the anesthesia side or the pain side, and I can picture that patient from residency, and I know how to better treat the patient today. I think sometimes you get too wrapped up in the tests, and you kind of lose sight of why you actually wanted to do medicine.
Yeah. What do you like the most about being a pain medicine specialist?
I think it's you get not necessarily instant gratification, but you do get a much quicker result to some of the interventions you do, whether they be medicines or procedures. I think having patients call back and say that they're doing fantastic, and they're walking their dog for the first time. They've gone back to sleeping in the bed with their significant other for the first time because they weren't able to lay down in bed for 6 months, a year sometimes. I think you get that kind of constant feedback, which for me is, it helps kind of keep pushing me along. There's a ton of value in monitoring hemoglobin, A1Cs, and blood pressures. And, my wife is a primary care doctor. I admire people who can stay on top of their patients and really help them long term. But I enjoy the slightly, the more, I guess, the gratification that you get from treating someone and seeing the result within 3 days, 1 week, 1 month, whatever it may be.
What do you like the least?
I think a lot of it is you sometimes feel like when you're seeing new patients and they don't necessarily agree with what you're recommending, and you try to go over the general recommendations for various pain societies or medication recommendations, and sometimes when there's just no seeing kind of eye to eye on the best way to continue treatment, you almost feel like at times you're disappointing them, and you obviously want the patients to be happy with your care. You want the patients to be happy with their progress, but sometimes there's just you have the occasional patient that you just aren't. You may not be the best physician to take care of them, which it hurts because you want to do what's best for them, and sometimes just having them get a second opinion or see another doctor may be what's best for them, just so they may hear the same thing again, or they may get a different opinion that fits more in line with what they're expecting for treatment.
Yeah. Do you see any major changes coming to the field of pain management?
I think pain is an interesting thing that even from this early part of practice, from fellowship, from residency, I think it's changed significantly. It's a big thing is obviously guided by what the insurance companies will and will not approve. Oftentimes we reach a stalemate with some of these insurance companies because we will show them the data for various procedures, and we'll show how this is the perfect person for that procedure based on their pain. And you spend hours and hours kind of fighting with them on the phone. So I think it's something that each day, a procedure that may have been approved by a certain insurance company, 1 week, 1 month later, they suddenly decide to stop. Right? Then you have to kind of come to the patient and tell them something that's been working for them for months or years is no longer being covered. So I think that's something that's difficult, in just trying to get some of the newer procedures accepted. Often it's without a lot of data, it's hard to convince them that something may work. So I think it's just kind of trying to stay up to date with the research and trying to convince the different insurance companies that this is what's best for their patient. It may not be best for what may not be best for their bottom line, but maybe what's best for the patient.
Yeah.
So I think that's just constantly changing some of the options that we have, and sometimes you have to work with the patient, work with the insurance company to find something that you can do to try to help them.
If you had to do it all over again, would you still be a pain management doc?
I would. I think it's, pain is something that affects you from the second you wake up to the second you fall asleep, which a number of my patients tell me they can't sleep because of the pain. So this is affecting people 24/7. There's no break from it. And that, it really, really affects their quality of life. So any improvement, you'd be surprised. Sometimes we have people come in and they go from, many people hate these pain skills, but they go from an 8 or a 9 down to a 5 or 6. And at first you're like, oh, that's not the win, not the home run we were looking for. But they come in and they're so happy they're crying because now they're able to, like I was saying before, walk their dog, go spend time with their kids or their grandkids. Our goal is always, if we can get you to a 1 or 2, a low nagging pain, that really, really changes every moment of your waking day. And being able to help people in that way, I think is something that pushes me and allows me to kind of continue every day to try to be the best doctor I can for them.
For the pre-med or medical student or even resident listening to this, thinking about going into a pain medicine fellowship, what words of wisdom do you have for them?
I think it's with every step, and everyone who's made it this far, it's every step of this is competitive, but just kind of keep in mind what you kind of see as your long-term goal. There's going to be various speed bumps and roadblocks, but I think if ultimately you have that goal in mind, you'll get there. And there may be a certain test that stays in your way or a certain class that gets in your way, but just kind of persevering through it, and ultimately finding the how to kind of get to that end point. It may not be the traditional path, it may not be the path that everyone else is taking, but just kind of keep on that path, and you'll get to the end result that you want.
All right, there you have it. Hopefully that was a helpful conversation for you and your journey into the specialty of your choice. If you are new to this podcast, if you are new to all of my podcasts, and you are interested in learning more about USMLE Step 1 going pass-fail and what that means for you, go back to last week's Pre-Med Years episode 380. You can find it premedyears.com/380 to hear my thoughts on the change. Hope you have a great week. We'll see you next time here on Specialty Stories.
This is MedEd Media.